So maybe it's time to start, as we have all the speakers and moderators and also our commentators. So, Professor Kato, if you allow, we can start the webinar.
Yeah,
Okay,
we are so happy. Hi. So we are so happy to receive the Dr. Chirag. He is one of the best friends from India. So, Keiki, are you listening?
Yes,
So
yes,
I
of
think,
course. It is
okay,
my honor. It is my honor to be.
Yeah, thanks.
Yes.
Thank you very much. And also the second, the speaker, the Solanki is okay. His name is Solanki. He's also from India. So today is maybe Indian day, Indian Indian conference. So let's start. Thank you very much.
Thank you, Professor Kato, for your words as an introduction of our webinar today. It's my pleasure to welcome, of course, Professor Kato and our speakers today. We have Professor Keiki Turel and Dr. Chirag Solanki. They will talk about very interesting topics. I want to thank our commentator today, Dr. Tushit Mewada, my dear friend, and a board member of our Alumni Association. Hello, Tushit, and welcome also to my co-moderator, Professor Ishu Bishnoi, and to our discussant, Dr. Sukirti Chawan and Savanas Biswas. So let's start. It's a great pleasure for me to introduce a really big name in international neurosurgery and also a dear friend of mine, Professor Keiki Turel. He actually does not need any formal introduction because he is very popular and he is quite famous, especially for pointing out the importance of complications avoidance in neurosurgery. He just completed successfully the 5th edition of the Congress about complications in neurosurgery in Goa, India. And today he actually will talk about avoidance of complications in neurosurgery, which is extremely important topic, especially for young neurosurgeons who must know before then giving something good to the patients, how to avoid giving something bad to the patient, so avoiding complications. So, Professor Keiki Turel, please, you can share your screen and start your lecture. Thank you very much.
Can the screen be seen? Can you see our screen?
Please share it again. Please share it again.
It is different from sequel. A sequel is a continuation of an earlier event or an after effect of surgery, which is an inherent thing to the procedure. For example, if you have pain, inflammation, or vomiting after surgery, this is not a complication. It is a sequel. It is an after effect of surgery. So sequel is a pathological condition resulting from a prior disease, injury, or an attack, like hydrocephalus coming after meningitis or subarachnoid hemorrhage, or wasting or weakness coming after poliomyelitis, or hair loss happening after radiotherapy or chemotherapy. So these are sequelae. How will you term these conditions which are not so infrequently experienced, like intraoperative aneurysmal rupture? Is it a complication or is it a sequel? Brain edema during or after tumor removal, seizures during awake surgery, or tactile syndrome following removal of the posterior third ventricular tumor. Do you call them sequel or complication? How will you term excessive bleeding during surgery? Is it a complication or is it a part of the disease? So trying to remove that last bit of meningioma adherent to the invading carotid artery, that certainly is a misadventure. So similarly, a hole in the internal carotid during transsphenoidal or puncturing the basilar artery during ETV, these are disasters that should never occur. So therefore, one should not confuse between a sequel and a complication. The patients need to be informed or forewarned of the possible events that may occur during surgery or thereafter. So this clarity in our mind will clear the air between our patients and us. We know medicine is a very uncertain field. There are no guarantees. With knowledge and experience together, by themselves individually, they have limitations. But when you combine knowledge and experience, it is wisdom. It's hard to find wisdom. In medical practice, mistakes are not allowed and they are seldom forgiven. For example, you see there's a tombstone in a graveyard, a real tombstone in India, in my own state, which says that so-and-so gentleman, father of so-and-so, died on this date due to negligence of this hospital and this doctor. This is a very unfortunate thing. It is better to be etched in the memory of people than on their tombstone. Every medical field has complications. Complications in neurosurgery can be devastating. They can be intraoperative or postoperative. They can be surgical or medical. So we have two sides of the coin of complication. One is prevention or anticipation, and the other is management. Both management will be immediate and late. And late management not only concerns the patient, but also dealing with the family. I always say 5 P's of prevention. Proper planning prevents poor performance. So we say failing to plan is planning to fail. And therefore, planning is very, very important. Before you hold a knife in your hand, you must have the full plan in your mind. And this prevention begins with the physician. He has to understand the case. Proper history, examination, and interpretation of images are extremely important before you start the operation. Having made the diagnosis, then you plan forward and backup. You plan not only all the steps in the one direction, but also what happens if something happens in between. And if your original plan fails, then you must have a plan B in your mind as a backup. So approach to the disease or the lesion, you must determine the goal or the end point, what you want to achieve or where you want to stop. Preparing, it is not always necessary to stop at the end of the tumor removal. Sometimes you may have to stop earlier. And you may get this information by looking at the scans. You may find an encasement of carotid artery and the arterial cord being affected. It must be prepared to stop at some stage instead of rupturing the artery. So preparing for intraoperative equipment and usables, preparing for intraoperative and possible postoperative events, specifying and assigning the role of each team member. Everyone must know what his job is, and running through the checklist or the WHO manifesto. Also, we should prepare the thigh if you anticipate that you will require fasciolata for repair of the CSF leak, of the dura tear. And this can be in transfemoral, it can also be in posterior fossa or brain surgery. Similarly, you may have to prepare the saphenous vein from the leg if you want to do a bypass, or the neck if you want to have a proximal control of the internal carotid artery. So all these things have to be planned in advance and not to make a rush after some insult occurs. We should not have an attitude of we will open and see. In India, we say chalta hai or dekh lenge. This attitude means we will see when it happens. No, we have to anticipate. There is enough imaging available to accurately predict and to help you prepare yourself for what may happen. Therefore, I say it is easier to stay out of complication than get out of complication. And anticipation helps. For example, knowing how to get in and not preparing for an escape route can get you trapped. So this is in India, we call it chakra view. It's called labyrinth. So that means when you go inside through a complicated path, you must know which are the parts and how you can get out of it. Once you get inside and you get lost, you may find yourself in a very big crisis. So prepare yourself. Don't get lost in the maze. As Hippocrates always said, prepare yourself, primarily do no harm, which means that you must know also your own limitations. If you're not equipped to do full justice to the case, you should not do it. Give it to a colleague who can handle it better. And you will not lose the patient. On the contrary, you will always gain his or her trust and confidence and respect that you refer the patient to the right person. Everyone, for example, I'll show you a case. Everyone plans how to open the multi-walled skull. but not everyone plans how to close and come out of it. An overzealous extensive opening for a skull-based lesion and not sparing the tissues for a good closure can lead to serious consequences, especially CSF leak and meningitis. I'll show you a case. Are you all following it, what I'm showing, the slides?
Yes, of course.
Yeah, okay. Yeah, okay. So this gentleman saw me in 2016 with severe headache in upright position. The moment he sat up, there was headache. Drowsy, very much in distress. He had a trigeminal schwannoma, which was excised by the left temporal craniotomy at another service a few days earlier. This was his actual preoperative scan, which shows a large schwannoma going through the skull base into the parapharyngeal area. Now, a craniotomy was done by the doctor, and at the end of the operation, he closed it. And immediately post-operatively, on the very first day or second day, the patient started complaining about severe headache. Obviously, the cause was a very severe amount of pneumocephalus. Now, why did his air get in from that area? So, in order to, having noticed that this air was, pneumocephalus was a cause of his headache, they did an endonasal transmaxillary endoscopic approach to try and repair the skull base from below 2 weeks after the original craniotomy. But this proved unsuccessful. Then they attempted, then there was a very large unrepaired skull base following this partial excision, and the patient was then referred to me for doing something. Now, this is a video which shows the patient in a very great distressing condition. You can see.
आपका नाम क्या है?
So you see, he's after such a good mold, he is not even able to speak. Okay. So I said we have no choice. We have to open up this area and once again see what is happening, how we can repair. And to my surprise, I found so much of schwannoma was still lying inside. So I went on dissecting, removing more and more, and came down to the root of the tumor. The root must be a trigeminal root. And very soon, at the end of this, I found that's the root from where the schwannoma is arising. We cut that root off, removed the remaining tumor, some of the packing material which they may have used at the endoscopic. And now I can see the whole big defect. So I told my anesthetist, there's a huge defect, you put in a Foley's catheter. So Foley's was put inside, and then I said, in order to close this gap, you inflate it. So we inflated and filled up the whole space, that whole skull base defect with this catheter. And I decided to repair the skull base with type fat, with cartilage, with bone, and kept the Foley's catheter as a support for this repairing material from above. And having put this, then of course I put some glue and fixed it, kept the Foley's in for 3 days, and then gradually withdrew, gradually deflated the Foley's catheter, and then removed it after 3 days. So this is the cranial repair done. And 3 days after I, removed the Foley's, I did a scan. There was still some air over there, but the patient was completely relieved, and he was absolutely fine.
Left side.
He got away. Now the wound is already healed, and he has no distress. So, what is the lesson we learned? The lesson we learned was that we should prepare ourselves not only for the opening, but also for the closure. Very important. That means sometimes you have to do your work from outside in. So this safety checklist has been given by WHO, but you can, like they have sign in, time out, sign out, which has been read out in the operating room by the sister or by the doctor or by the anesthetist, whoever. But you can have your own departmental checklist as it suits you. But this is the one which we are following. I have enumerated some of these risk factors, and I will be giving you one example for each of these risk factors. For example, inadequate training or lack of maturity is one of the reasons, is a risk factor why complications occur. The surgeon must be well trained by cadaver, by training, by whatever way you want, but he must be mature and must be trained to take up such a case. For example, you have to train in the cadaver lab. I'm doing this cadaver dissection demonstration in Salim Abdul Rauf's department in Missouri, in St. Louis. And the second middle one over here you see is I'm training my own son Mazda under a microscope for a vascular anastomosis. This was many years ago when he was a resident. And then we train. So first level is cadaver, second level is laboratory, and then the third level comes surgery. Today, resident doctors want to come straight to surgery, want to wash up, and want to learn their microsurgery straight in the operation theater. That is not the correct way. You have to work on cadavers and in the lab before you scrub up for surgery. So if you spend more time preparing, you will spend less time repairing. That is the importance of training. What about anatomy? So this training in the cadaver lab will give you ample experience if it's anatomy. And this can be, if you do not have the capability of good anatomical experience, you may make a mistake. This was a young school teacher who had severe trigeminal pain, and she was in a very bad condition. I suggested to her surgery. She went home and said, okay, I'm coming and enrolling. And then I was out of the town. In the meantime, she developed a very severe amount of pain, almost suicidal. And there was no time to contact me. I was away. She got operated by another very experienced neurosurgeon. This was the MRI. And after that surgeon's operation, she immediately experienced some deafness, severe tinnitus, but surprisingly, no relief of her pain. She said, I don't mind deafness, I don't mind tinnitus, but the pain is killing me. She consulted the surgeon many times, so they gave antidepressants, pregabalin, and everything. But they said it was not helping. So then she came back to me, and I spoke to the surgeon. He said he has done a perfect MBD, and the patient was probably being a little too demanding, too impatient. Now, when you have such a patient, and when the surgeon, experienced surgeon has this problem, what do? I decided to re-explore her. And you must remember, after cerebellar retraction, what is the first thing that you will see? The cranial nerves will be visualized. This should have come later. Put it wrong. This is the place. Now, this is a Tübingen line. And a Tübingen line is the internal auditory meatus. These neural folds, where they open up, is exactly the point where you have the 7th and the 8th nerve. And very frequently, that 7th and the 8th nerve will be surrounded by ICA or branches of ICA. This is not trigeminal nerve, and this is not a neurovascular conflict. Trigeminal nerve is much higher and much deeper, near the tentorium. And that is the case. I'm not showing that patient. This is another patient, just to acquaint you with the anatomy. And that's a vessel which is going parallel to the trigeminal nerve and causing vascular conflict. So, what I did for this young lady who complained about this problem, I said, I have no choice but to re-explore and see what is the matter. So we did a re-exploration of the CP angle. I retract the cerebellum from above. In MBD for trigeminal, you always retract from above downwards. In schwannoma or vestibular nerve, you always retract from below upwards. So when you retract from above downwards, you first see tentorium, you see petrosal vein, and then deeper down, you will see trigeminal nerve. Now, as I am retracting, I am trying to find out, I don't find any vascular conflict. So I go down towards the 7th and the 8th. And as I go there, I find this piece of Teflon adjacent to 7th and 8th. This is the reason why the patient had tinnitus, deafness, and no relief, because trigeminal nerve is lying in another compartment at another level. So I removed the Teflon, and then I brought the trigeminal nerve down. I dissected it, and you can see the tentorium on your left side, the trigeminal nerve on the right side, and this vascular loop has been separated from it. A piece of Teflon is put over there, identifying the nerve right from root entry zone up to Meckel's cave, to make sure that we have seen all the vessels 360 degrees. And to keep that Teflon in place, you may inject some fibrin glue. So that was the operation. Sometimes people make mistake of anatomy. And now you can see the result. She's extremely happy. She's feeling of pain and a very happy result.
Yeah, you should have seen.
And then, since we wanted to show this case again, I called her. This is after 9 years. She came after 9 years, and she's pretty happy. It is continuing to remain pain-free. Wonderful. The next point is wrong choice. Wrong choice of patient, wrong choice of approach, and wrong choice of technique. I'll show you some cases, and my own cases. Now, this is a patient who was referred to me after another surgeon had operated with a GBM, but the cancer specialist, the chemotherapist and the radiotherapist told me, no, there's a big tumor left behind. We cannot give radiation chemotherapy. Please go in and remove this. Now, I operated on this patient. It was a GBM. Probably there was not much. There's not only one GBM, there's a second, another nodule over there. But I'm a very aggressive surgeon, so they said, please remove this. And I go ahead and remove it. But you can see that you don't have a very good result. So this was, according to me, a bad selection of the patient. What about choice of approach? Nowadays, everybody says minimalism. Everyone says endoscopy. Less is more. Modernism, minimalism, less fuss. Let's choose the shortest and safest route. I think it's a very good idea. I do not deny it. If you look at the history of neurosurgery from a very maximal approach, now this is Walter Andy's approach to an aneurysm at the skull base, ACOM aneurysm. You can see the craniotomy and you can see how large it is for him to reach to the bottom. Of course, there was no microsurgery. But so from very large craniotomies, we have now come down to very small craniotomies, small approaches, small corridors leading to big spaces. And we have learned this from all our colleagues and our masters. I was a good friend, very close friend of Axel Perneksky. And I have been to his department. Together, we did a workshop on minimally invasive in the SQLAP Academy. And I learned a lot during that time myself from Axel. So we choose nowadays small approaches, small entry points to enter. Everybody knows now that in microscopic surgery, you have a funnel which is going from broad to narrow. But in endoscopic surgery, you have inverted funnel, which goes from narrow to broad. For a long time now, we have this minimal supraorbital craniotomy for surgeries at the skull base, anterior skull base, not only for tumors, but even for aneurysms. Sometimes not only for the same side, but even for the opposite side. But we must know, we must have a clear idea of what you can do from that approach. You may find it very difficult sometimes to go to suprachoroidal tumors to the opposite side, especially if the clinoid is or the sphenoid wing is coming in the way. So you have to tailor your approaches. You have to plan your approach properly. Everything is not possible by the same approach. Not all kinds of tumors and all sizes of tumors. Now, this kind of a tumor we can easily remove. Now, but with our growing experience, we can now remove tumors of a larger size, so long as they are approachable at the base of the skull, and even larger than this. Olfactory groove melangiomas can be removed. Even planum sphenoidal tumors can be removed. And what about this? Would you remove this anterior skull base by the supraorbital mini craniotomy? I would say I would be very, very gingerly. I would not accept such a case by that approach. You know why? There's so much of cerebral edema around. And by the time you make your craniotomy, you open the dura, you may probably find a lot of difficulty with the brain, edematous brain, chasing the tumor or preceding the tumor. So these kind of cases, though you may have experience of supraorbital, now we are doing it for more than 10 or 15 years, but I should choose my case. And I should probably say no to this kind of an operation. At one time, we also felt that this kind of a tumor, it is impossible to remove this endoscopically. Look at this carotid artery and look at this one, which is completely engulfed. The cavernous sinus, the tumor encroaching, is going into the temporal area. The dura is there. The dura is being lifted everywhere. So one may feel that as long as you remain inside the tumor and keep on breaking it down, you are safe. You are not going to enter the brain because there is a thick dural covering. So how would you approach this? It depends on your experience. Would you follow the elitist endoscopist, or would you then go by a craniotomy, by a traditional transcranial, or would you do it in 2 stages, maybe 2 simultaneously? Maybe you go endoscopic at one time and at the same time we go from the cranium. So there are many ways to skin a cat. But it all depends upon your experience and your anatomical knowledge and your training. So what is ethical? Similarly, for this kind of a tumor. So you have to decide for yourself, not because somebody else can do it, you can also do it. You have to tailor the approach according to your experience and training. So we may do a supraorbital approach for a craniotomy for an aneurysm. I have removed some aneurysm, I have clipped some aneurysm from this route, but I would still keep this option available, pterional craniotomy, classical craniotomy for aneurysms in the ACOM area also, and in the middle cerebral particularly. So there is still room for traditional approaches. So you have to consider this learning. Learning is a lifelong journey. It is a never-ending endeavor. And you have to make your own path. Make your own path as Moses made when he parted the Red Sea. He made his own path. And third point is choice of technique. This boy, young boy, 10 years old, was referred to me with this tumor. It looks a very angry, very devastating tumor. I did not think much about it. I said, this is a standard frontal operation. I did a frontal craniotomy. And then I went by the classical sulcal route. All my intraaxial tumors, I operate through the sulcal route for the last 30 years or even more than that, ever since. So I opened up the sulcus and then separate the two gyri, and very soon I would strike the tumor. You can see this gray tumor like over there. Gray matter, white matter, and the tumor. Dark gray matter. So our standard teaching is that you do intratumoral debulking, correct? And so I start biting the tumor from inside so that we do not put any pressure on the neighboring white matter. And as I'm doing, bleeding starts. And the bleeding is not only it started, but it cannot be stopped. It goes on bleeding. You can see very large blood vessels inside the tumor, and they are so large and they are so calcified that they cannot be coagulated. So you try to do coagulation, it just remains like a rigid fibrous strand. And he's a young boy, the patient is going on bleeding. We have to tell the anesthetist to get some blood for this. And I try a very rapid tumor debulking so that we can minimize this bleeding. In spite of all our experience, we find that this bleeding was quite torrential and quite unmanageable. And you see, everywhere there are blood vessels. Now, our standard training and standard teaching go intratumoral. Nowadays, of course, we have got a different philosophy for gliomas, and we can do a supramarginal resection by another technique, which I will talk a little later. But you see how this bleeding is. It's a very vascular tumor. And as we go more and more inside the tumor, it bleeds even more, which is quite the contrary when we are experiencing vascular tumors. The more you remove, the less it starts, the less it bleeds. But here it went on, so I had to stop. Finally, with some difficulty, I managed to stop the bleeding. I did a post-op scan, and it looks like I have done nothing. With all this 2 or 2.5 hours of surgery, the tumor is still the same. I spoke to the mother of the boy. I said, I'm very sorry, but I still believe that gliomas must be removed completely in order to give them the best possible surgical result, which is, I'm talking about 20 years ago, but today we all know this story that maximal safe resection should be attempted in every glioma, whether it is a low-grade glioma or a high-grade glioma. So if goes totally, of course, unachievable due to some intraoperative difficulty, you can still regroup, replan, and reoperate to achieve the surgical goal of maximal safe resection. So this is what I did, especially in a young patient. It can contribute to a longer survival. So in a residual glioma, it is worth reoperating. So I spoke to the mother and I said, please let me reoperate. So 10 days later, she agreed, because I said I can give you a better result if I go in again. But this time I had a different plan. So I'm opening the same wound. Now, this time, I'm not going by the same sulcus, but I'm identifying a sulcus far away from all directions, circumferentially. So I approach this tumor from different area. So we have regrouped, we have replanned, and we have made a different concept of removing this tumor. And because of my previous surgery being very vascular, and very bloody, I thought we should go by the least vascular route. So I go right up to the midline. I'm separating the brain from the fox very carefully, not allowing anything to bleed. And step by step, I separate this whole frontal lobe, including the tumor, away, and going by this least traumatic route. And then I remove this whole tumor, as you can see, with practically no blood loss, because now I am outside the tumor, and all the blood supply from outside, I have trapped, I have cut it off. So you cut off the enemy line, and having cut off the enemy line, you can give a good result. And this is the post-op scan. The tumor is out, and in fact, he has now got a very relaxed brain and a small subdural hygroma, which of course settled down very quickly. So small exposures, but not unduly cumbersome, reaching the lesion through the shortest and straightest route is today's concept of neurosurgery, minimally invasive, so that there is least trauma to the brain, cranial nerves, and blood vessels. So we say KISS, keep it small and simple. Very nice, good idea. And complexity and contradiction to make way for simplicity and consistency. But please take each case as it comes, not everything. Please understand, there are fads and fashions in neurosurgery. Minimalism is nowadays in fashion. So be fashionable if fashion suits you. If it doesn't suit you, then please remain traditional. So there has been, of course, a great revolution in neurosurgery by keyhole approaches. You should train for it, and if it suits you, you do it. Next is overzealousness. This was a young woman who only had some headache and one seizure. Severe headache. And we did the MRI. She had no neurological deficit. And you can see in the singular area, she has got this large AVM. I spoke to the family. This is the AVM. I spoke to the family that this is an AVM according to Aruba trial. At that time, the results of Aruba trial had come out. And they said if the patient is practically asymptomatic, there is no reason to do anything. Wait for something more to happen. But I was, I call myself a rather over-enthusiastic, if not aggressive surgeon. So I did an angiogram, of course, because I told them that it is my personal philosophy, that if we remove this AVM, then there is a possibility that she will not bleed any time in future. And because a bleed in this area may make her permanently paralyzed. So we did an angiogram, and you see a very large anterior cerebral arterial supply. Also, there is some middle cerebral supply coming from lateral to medial. And I asked my embolization technology, interventional technology doctor to try and embolize something. He did embolize, but it didn't make any difference, according to me. It made no difference to the operation. So anyway, I opened it. I thought the best way to do it is to operate. So I'm again opening out, going all around the AVM as we should. Very large craniotomy. We always like our eyes, not minimal craniotomy in AVM surgery. It's on the surface. Go all around, try and catch the feeders as they are entering the nidus, before they are entering. AVM surgery, everybody knows, can be a very bloody surgery, and you must be ready to face this bleeding and stop the bleeding. So we require many temporary clips sometimes, and to find out where the main bleeders are arising from, and put temporary clips. Even sometimes I've taken some sutures to stop the bleeding, and go on coagulating till you can reach from the small feeders to the mother artery, the one artery which is supplying, or from where these small feeders are arising. So you go as laterally as possible and go and remove this whole AVM until you reach the large draining vein at the end. And then finally, you disconnect the large AVM, the large draining vein, and remove the tumor. So I thought I did a good job. This is a post-operative angiogram. That very large carosomarginal artery supplying the tumor is gone. The AVM is gone. There is no problem at all. Okay, that's fine. But what about the patient? The same evening.
And again lift that right upper hand,
we are doing
left
next
hand.
Day.
Okay.
The left side
and
is
this leg,
well.
like okay. And try to move your left leg. Any toe movements, वगैरह? Nothing.
She cannot move. Now, we were all upset. We were all sad. This girl was completely normal. She was happy, healthy. And what have we done? We went back to the literature. At that time, it was explained this is a SMA syndrome. And within 7 days, she recovered fully. Fortunately, she made a full recovery from this SMA syndrome, or transient hemiparesis. So when she came for a follow-up, there you are. There is not even foot weakness. She is happy, and her husband is also very happy. It's a very good result. You can see that. That's the bifrontal scalp incision. So it's a quick recovery, and we were very fortunate. And few months ago, I called her again for a follow-up. And here you are, after 10 years of 10 years. 10 years of study. It's quite okay. You are vindicated. But we have to be careful about what we are doing. So I'm just trying to say that you can be aggressive and you can be fashionable, but you must know your limitations and you must take each case as it comes. Lack of anticipation. One more point, lack of anticipation. This was a 27-year-old lady. She came with headache for 1.5 years, double vision, diplopia, and she had a right lateral practice. And this was a tumor. This tumor is all around the skull base, all around the clinoid process. What do you do for this? It's a paramedian location. I decided on a surgical operation by a right subtemporal craniotomy. It was an extradural tumor, so I tried to excise this tumor. Now, this is the right subtemporal operation. The dura has been lifted, the brain has been lifted along with the dura, and I'm removing the tumor. And it is coming out very nicely, very happily. There was some bleeding, and suddenly it has burst. What do you think has happened? I have gone too low down into the skull base, and I have perforated the ICA, internal carotid artery. This tumor, if you look at the left side, you can see this tumor is all around the carotid. Is all around the carotid. Overzealous, and I did not anticipate that it will bleed. I should have expected that it will bleed. So I'll play it again. So I asked my assistant, and he immediately opened the neck and compressed the carotid artery. I also telephoned my endovascular interventionist. He was not in the hospital. This was a Saturday evening. This was the third case of the day. And it was foolish of me to do that. And I realized this mistake. And fortunately, he came running from another department with a balloon in his hand and came. Fortunately, we were operating on a table which was allowing us to do an angiogram. So we did an immediate femoral puncture, did an angiography, and after doing an angiogram, we see that. So what do you do? As when you have the bleeding, at first you control yourself, then you control the bleeding. So we stopped the carotid artery from the neck. Then we called our endovascular. He did an angiogram, very good cross flow. We felt relieved. She's a young girl, 27. And this is a big cotton blob, which I kept. That is why the whole thing has got elevated. And then he put in, but at those days we had balloon and coils. So he put Boyle and Canoon inside. And and we did a post-operative scan after 2 weeks. And you see there's a lot of tumor left over there. And there's also a lot of, and maybe balloon inside and coil inside, but we are seeing a big residual tumor. So after 3 weeks, I decided to go in again because it's a chordoma. And chordoma, the best treatment is total excision. So I go in again. This time we are prepared. The carotid artery is already blocked. I have nothing to, patient has no neurological deficit except that 6 nerve which was there. And then we operated again and we took it out. And this is the lady post-operatively. You can see that there's a big scar on the sternomastoid for opening the carotid artery in the neck, but we did not anticipate. But fortunately, we could save her, and she also recovered from her 6 nerve. So that was a good result, but we could have lost her. So anticipation, very important. That's the next point of of a high risk factor. Wrong decision making. Next point. What about the decision making? Now, should we always recommend surgery? Because we are surgeons, we always think that surgery is the right answer for everything. We should consider surgery against the background of patient's expectations, against the disease, what it is, and against the life expectancy accordingly. So choosing between what is good for the patient and what is good for you as a surgeon. For a surgeon, surgery tends to be the first natural choice. But as a surgeon, we must know that surgery is not the only way. Surgeon must know in their wisdom when not to operate or when to control the surgery. For example, would you operate on butterfly gliomas or recurrent GBMs? I already showed you that this was not a good idea. But sometimes we do it and sometimes we don't. So we have to take each case as it comes. Attempting radical, so even butterfly gliomas, I have done sometimes, but that is because it arises from one frontal lobe and invaginates into the under the fox to the opposite side, but I am still preserving the opposite frontal lobe. If I am going to damage both frontal lobes, then I should not be operating on such a glioma. Attempting radical excision of skull-base meningioma, encasing or infiltrating the carotids or the cavernous sinus. You must be very choosy, decisive. What about asymptomatic, small, non-growing benign tumors, especially like meningiomas in the elderly? I've got some cases like that. They are not growing. Would you want to take the risk of operating on an old man who has got a small non-growing tumor? It may be one more operation in my hands. It may give me some more money if I feel that is the right thing. But no, what is good for the patient is good for the surgeon. That is important. So consider all these factors in order to reduce your complications. That is called anticipation. Now, having said that, I am making the same mistake. This is a big infiltrating glioma. You can see it's GBM. It's going all over on the same side, on the opposite side. And I said, sorry, I do not operate on these patients. I won't even biopsy it. The diagnosis is very clear. The family was upset. He says, no, we have heard so much about you. You are such a great surgeon. Everyone that you operate gets well. I said, no, this is not the case where I can do anything. You have to ask God for help. I am not that. So they went on. They came again after 5 days. Again, I said no. And then I was out of town and the patient was having severe seizures. So they got admitted under my care, in my name, in the hospital. And the next day when I came back, I saw the patient in the ICU. Now the family says, please, doctor, he will die. You have to operate. Please do something. Now, what do you tell them? I said, I cannot operate. He says, no, but if this patient dies, you will be responsible. I said, if the patient gets worse, then would you take the responsibility? He says, yes. So this was a kind of an argument we had to and fro. Honestly speaking, I should have just taken it in writing. I operated on the patient. Now, let me show you. This is the patient before operation. He has just woken up from his anti-epileptic pentothal, IV pentothal. He is able to converse. He is able to follow, gesticulating. He has got some degree of power. At least he is conscious now. He is very weak, but he is able to. There you are. Now the family is. He's got some weakness on the right side. Okay. The family told me to operate. So I fell in the trap. I fell in the trap and I did a big bifrontal craniotomy, removed whatever I felt was abnormal, allowed the brain to expand. You can see what an ugly looking brain it is. I can say I'm certainly not proud of this. And what happened to the patient? The patient who was conscious, he was obeying commands, he was moving his limbs, is now vegetative. He's on a tracheostomy. Yeah, holding the leg. Yeah, but provided it's a good response. You think this was the right thing to do? I should have said no. Avoiding complications. Learn to say no. And the last point is technical reasons. This was so we can have problems. You know very well the complications of taking a patient for MRI. We had this accident in one of our hospitals. The patient was taken in a trolley in the magnetic machine and everything got sucked in. And the patient died and the ward boy, the whole oxygen cylinder went in and the ward boy also who was accompanying the patient, He also died. So you can have complications with machines. Let me show you one case. This is a patient who has this beautiful, well-rounded, perfectly localized lesion. We did a PET scan, but we did not find any. I thought it was a secondary, but it was not. So we said, okay, we have to do a biopsy of this. It was an elderly lady. So we did a navigation. And after doing navigation, I'm navigating and I'm going into the tumor. I'm getting a biopsy. The biopsy report says nothing, no tumor. Oh, I take another trajectory, another biopsy, no tumor. Another biopsy, no tumor. Now 3, 4, 5 biopsies, and I'm turning my pointer from different directions, and not a single tissue report was positive. What do we do? I was really surprised. And then my anesthetist suggested to me, why don't you do an ultrasound and see what's happening? So the lesson to learn is listen to everybody in the team. You may sometimes feel that anesthetists don't know anything. Your junior doctor may not know anything. Your nurse may not know anything. They may sometimes come up with a bright idea. So listen to everybody in the team. And this was a great idea given to me by my anesthetist. We put ultrasound, and what did we find? We were 3 centimeters away from the tumor. Now, why do you think this happened? This happened because the patient was done MRI in a supine position. The patient was positioned in a slouching, semi-recumbent position. And on top of that, because of looking at the edema, the anesthetist on her own free will gave anti-edema mannitol. When mannitol was given in a semi-sitting position, you can imagine the whole thing moved. And that is why we did not have so technical errors can be there. Navigation errors are now described. This was the case we presented in our first ICCN in 2017. So I'm bringing it again to show it to you. Similarly, we have problems with intraoperative neurophysiological monitoring. And we had a very beautiful discussion. And Alberto Felletti knows, he was a part of this discussion in Goa meeting, where we had the full Italian delegation discussing their idea about the positive, false positives, false negatives, and the value and the role of IO and M. And at that time, we presented this case. My resident presented this case. This was a large acoustic tumor, giant tumor. We removed it. The patient had surprisingly good hearing. Can you see this? It was a slow-growing tumor, so the hearing was still preserved. And this is the tumor with this kind of hearing. And we were very careful. And we were very... that was his facial nerve function pre-operatively. And he had good facial function. No nystagmus, no cerebral signs. You can see very nice looking, but you can see the tumor, not a very good tumor. So he was well preserved. Hearing is there on the left side. So we did monitoring of all the nerves as usual. And and this is the operation. So we do monitoring. The monitoring is going on. This is the CP angle exposure, cerebellum. I opened the arachnoid of the tumor, around the tumor, and I'm straight inside the tumor. I'm debulking. It's a large tumor, so the natural thing to do is make a large tumor small and a small tumor smaller till you can reach all the margins around the tumor. And I can see now, after sufficient decompression, I'm able to see the facial nerve. I'm peeling it off from the brainstem area. Then I'm going laterally, I'm going superiorly. So you go around, merry-go-round, as I say, go all sides. Keep looking at the nerves. Use CUSA, use tumor material, do whatever can help you to debulk the tumor. But keep your eye on the cranial nerves. I always say the trade secret of acoustic surgery is preservation of cranial nerves, identification and preservation. Tumor removal is a byproduct. So here you are, you can see me. I'm still searching for the nerves. I'm not worried about the tumor. Tumor will come out. I'm going on hunting for the nerves. And my neuromonitoring is on, so I'm getting the signals. So you can see my neuromonitoring probe. And then I can identify the H nerve. Then I'm using a hook to deliver this. And I'm constantly monitoring the 728 with my monitoring probe, and here I am at the angle at the porous acousticus, debulking it from there and then going in. 728 now, preservation. So here there's the 8 now. That's the 8 now, that's the 7 now. And the last bit of the tumor is being removed from the CP angle. And the monitoring says the BERA is good. BERA is constantly present. So we were very happy. I said, damn good. We are, with such a large tumor, we are able to preserve the hearing. BERA was good. We closed it. After closing it, we then saw the patient. He has to go out. So that is the patient. So immediate post-operative, not immediate post-operative. Immediate post-operative already seen. But when the patient is a little better, you can see. That was pre-operative. Is it pre-operative?
No, 25 days.
It is post-operative. Okay. The 5th nerve is all right. The 7th nerve is all right. Hearing is good. And facial is good. But we will see that he has lost his hearing. Yeah. Oh, he's pointing out the hearing is gone. So we did his audiometry also and see his hearing has deteriorated. But during the operation, he had good hearing response, good BAER. Now, this has been January. I think we will have to call our patient again to see in April whether he has got any hearing improvement. But I'm not very sure what to find, what to expect. Of course, patient did not mind because he was told that many bad things can happen. So this is post day 25. He has no hearing. All right. So, but I don't think I have time to show any more cases, isn't it? What do you say, Alberto? Do we have time to show any more?
Actually, we are already over 1 hour.
Already late.
At the beginning,
so I think we will wind up. So
yeah.
I'll just show you. Okay, this is another acoustic. This is another acoustic tumor on whom I did a radical removal. And immediately after removal, you can see the patient. He's got a facial. I'm sorry, this is not that. This is the. Immediately after removal, he has got a facial nerve palsy. And not only that, but he has got a 6th nerve also. So there's a 6th nerve and a 7th nerve. But then after 3 months, now his facial nerve also was working during the operation. But post-operatively, I found that it was not working. But later on, we realized that he had a small pica territory infarct, which recovered. And then his cranial nerves also recovered. But during the neuromonitoring, we found that the facial was intact, but immediate post-operative, it was not so. Anyway, so that's, so I won't go through the whole thing. Finally, we say that we learn by making mistakes. Errando discitur, we learn. So if you must decide upon 3 things at the start: the rules of the game, the stakes, and the quitting time. So you must now realize I'm going to quit. And before I quit, I again say it is easier to stay out of complication than get out of complication. So understand all the risk factors before you take your knife in your hand. We have had these beautiful 5 conferences on complications. 5th one was in Goa. And then we have published 2 books on complications. And the next conference will be in Rimini in Italy, 4th to 6th June 2026. And we are all looking forward. Already I have started talking about it in India. And I have 20 people who have already asked me to register the names. So I think, Alberto, you have to be prepared for a few extra hotels for these people. Thank you very much. Thank you so much.
Thank you.
I'm sorry for crossing my time.
No. It was a privilege to hear your talk, and we really enjoyed. Thank you also for pointing out that next Congress on Complications will be in Italy. Actually, it's a very good advertising, and we will be ready with all the required rooms and hotels. No worries. Okay, so great. Thank you very much, Professor Keki Turel. Really inspiring presentation, especially for our young neurosurgeons. I think we can open the discussion. So I kindly ask my dear friend, Dr. Tushit Mewada, to give his comments on this presentation.
Thank you very much, Professor. Very nice presentation. And again, thank you very much for actually, categorizing all the high risk factor of the complication and how to avoid it. And you have already showed very nicely that sometime out of the box thinking in these cases can be help a very great way in these parts. I would like to add that sometime whenever you call your IR doctor, sometime for the tumors nowadays, since last 5-10 years, it is easier to do pre-operative angiography and to embolize even artery as well as tumors for that part. So sometimes it is very easier to remove it that way. Older, the thinking part was only to embolize arteries. So nowadays, embolizing materials are there that we can partially embolize the tumor, and after that, if we start removing it, especially the skull-based tumors, which are more extradural in nature. So that might help. But you have shown your whole journey of neurosurgery of so many years that you have evolved, and you have shown the young neurosurgeons that how neurosurgeon can actually do great surgery in this matter. Thank you very much, Professor, for acknowledging us. Thank you.
Thank you.
Thank you, Tushit. And maybe we can also hear some comments and questions by our discussant, Dr. 𝒂𝒑𝒂𝒈.
Hello, good evening, sir. Thank you so much for that excellent lecture. How are you doing?
How are you?
So, I will ask you a very Gen Z question. Okay, you're the father of microneurosurgery in India. My Gen Z question is: the next generation, when they are learning surgeries, they are being exposed more to VR, virtual reality, and operating in VR. So what I feel sometimes is when we have assisted our professors, when the complications came during the surgery, the way our professors reacted, it taught us a lot. So is VR really helpful to that extent? Because I feel sometimes that the Gen Z doesn't feel the fear in them when a complication happens on a VR stage. So what is your opinion on handling complications virtually and really giving the junior doctors a training hands-on or being a part of the OR inside the OT complex? What's your opinion on that?
I think you have answered your question to stay calm in the presence of you stay calm. If you are calm, you will automatically be able to think correctly. I have seen surgeons who start swearing at everybody. The surgeon makes a mistake or the complication, and the anesthetist is blamed for the brain not relaxed. The nurse is blamed for not giving the correct instruments. I have seen surgeons throwing the instruments. I have seen them kicking the the people around. So I think a mature surgeon doesn't do these things. A mature surgeon will, if there is tremendous bleeding, first of all, you should expect it. No bleeding generally suddenly occurs from nowhere. If you have done your case study properly, you can anticipate. And therefore, you will always have, like you have giant aneurysms. You can have, or you even have a small aneurysm. For every aneurysm, I would keep an extra giant sucker available. And I would keep one sucker with the nurse's side also. So when I am operating with my two hands, the sucker must go straight to the point of bleeding, and the blood will go immediately into the suction tube. Then there is no more blood visible. And then you can calmly go get a temporary clip or a permanent clip and block it. The reason why bleeding causes a problem is because you can't see anything, and you can't see anything because you can't suck enough. For that, you require two suckers. Bring in a sucker at the whole of the bleeding, and one assistant will try to clear it from the surface. But a calm surgeon will be able to handle the situation. He will tell, okay, he will tell everybody, relax, don't worry, we'll handle it. So the mature surgeon will always be in complete control of the situation. I'm not saying it is not natural. It is natural to be concerned, but not to be fearful. Have I answered your question?
Thank you. No, so my other part of the question was, virtual reality, the way the juniors are being taught. So do you think that they're really getting the hands-on training? Is it good enough? That is my question. Also, part of it.
You are right. But see, just one type of training is not enough for surgery, as you know. They still have to go to the basics. They still have to learn the anatomy, still have to do the laboratory. There is no shortcut for safe surgery. Even if you are becoming an endoscopic surgeon, your microsurgical skills have to be there. If those skills are not there, how will you operate with your two hands?
Because nowadays all the technologies are just pushing things that you do it on VR, you become great, I don't agree with that, so I wanted your opinion, and I'm happy my opinion resonates with you.
Can you become 60 years of age without becoming 10, 20, 30, 40? You cannot suddenly become 60. You have to go through.
Oh God, I'm already 40 plus. Oh God. Thank you, sir. Thank you so much.
Thank you so much. Actually, yes, new technology is helpful, but it doesn't replace, right, the real experience. That's very important to point out. Is there any other question from the floor?
Yeah.
Issue.
Yeah. Thank you for the wonderful lecture, Professor Chirag. Because it was based on complications in neurosurgery. So if you find that you have done some error and it caused some complication and caused the deficit, so how do you explain it to the relatives? Do you acknowledge your error during the surgery that it caused the problem?
That is part 2 of my lecture. Part 2 of my lecture is morals and obligations and legalities. That's part 3. So, but to put it in I don't want to show you part 2 and part 3, otherwise it will be another 3 hours. So I've got everything ready. But I will tell you that it is, of course, very important to be transparent. But before you open your mouth, then explain to the family, first discuss amongst the team, what has happened? What are we going to speak? There should be one voice.
Okay.
Because sometimes a junior doctor speaks one thing, the nurse may speak a second thing, the orderly may speak a third thing, and the assistant and the fourth surgeon, everybody will speak different things. No, we have to sing the same tune. So the surgeon, in his maturity, will say, okay, this has happened, and this is what we have to talk. And I personally do it myself. I do not leave it to juniors. I will face the family. I will explain to them because I have the experience of doing it. And I have the experience of handling awkward questions. And therefore, the senior most person who is involved in surgery, sometimes the professor is not involved in surgery, the second man. So who is the senior most involved in surgery should make a group within the team and speak the truth. You must not be shady and directly look into the eyes of the family member and talk. Do not look here and there and shifty. Transparent, be upfront, accept that this has happened, and say that this, in spite of everything possible, this has happened, and we are going to take charge of it, and we will see what best we can do. This was not expected, or this was beyond our control, or the disease was like this, whatever are the reasons. Well, sometimes it can happen that I have seen sometimes gross complications occurring because of the anesthetist mistake. There is a tube got disconnected and you didn't realize it. Nowadays, you've got all the monitors to tell you. But sometimes people are working in places where you don't have those things. So the surgeon is the captain of the ship. Final responsibility is his. And he has to take the bull by its horns. And he has to take charge. And what you will say, they will decide. And once having decided, everybody will sing the same song. Anyway, and then you will visit the patient more often. You will talk to the family more often, and you will make them understand that you are doing your best. I'm telling you, if you do this, there will never be any litigation. Even though sometimes the patients are being instigated by other people. Oh, you've spent so much money, get it, you can book him. But the surgeon must be so graceful, so gracious, and so much in control that he always makes the patients his allies. You make your patients your allies. So that you should do this homework. This homework you should do even before you start the operation. The patient comes to you with full trust. They know that they've gone to the best person with the best morals and with the best ethics and with the best tools and the best experience. So if they have that comfort feeling, there will be no misunderstanding. I'm sure all the litigations are occurring because we are not communicating properly.
Yes.
Communication starts before the operation.
Thank you. Thank you for the advice. Thank you.
Yes.
Thank you so much. Other questions or comments about the lecture of Professor 𝒂𝒂𝒈? Otherwise, we can thank again very much Professor 𝒂𝒂𝒈 for a very inspiring talk and also a great discussion. And we can move on with the next speaker. So I kindly ask my co-moderator, Ishu Bishnoi, to introduce our next speaker.
Thank you, dear Alberto. So I would like to invite our next speaker, Dr. Chirag Solanki. He is currently working as functional neurosurgeon in Ahmedabad, Gujarat, India. And his special interests are in functional neurosurgery and Parkinson, movement disorder, epilepsy surgery. And he has done fellowship in functional neurosurgery. Today he will be talking on functional neurosurgery in movement disorder, a pragmatic approach. So I would ask Dr. Chirag to present, please.
Yeah, thank you very much, Dr. Ishu, for your kind introduction. And I am thankful to Professor Yoko Kato, Professor Raja, Professor Afalati for giving this opportunity on this platform. And I'll be speaking on the role of functional neurosurgery in movement disorders and how there can be a pragmatic approach by treating movement disorders by functional neurosurgery. So I think I've shared my screen. Is my screen visible?
Yeah.
Okay. So I'll be talking in brief about the pragmatic approach in functional neurosurgery in treating movement disorders. I have nothing to disclose. Just a second. Something happened. Yeah. My screen is visible, right?
Yes.
Yeah, okay. So I have nothing to disclose. So to start with the terminology of functional neurosurgery, the definition of functional neurosurgery involves multiple interventions like ablation, stimulation, modulation, transplantation. And all interventions are used to improve the quality of life of the patients by relieving the variety of symptoms of various neurological disorders. But there is also another vertical within the functional neurosurgery, which is called neuromodulation surgery. So how is it different from a functional neurosurgery? So out of all those interventions which I mentioned in functional neurosurgery, out of those interventions, a couple of interventions which are electrical stimulation and use of chemical agents or the delivery of chemical agents directly within the central nervous system. These two interventions are particularly considered as neuromodulation as compared to functional neurosurgery. But as the definition itself shows that the neuromodulation, it is a part of functional neurosurgery. And the aim of both of this is to improve the quality of life of the patients. So in crux, functional neurosurgery basically involves three types of interventions. The first is neuromodulation, which is the alteration of neurocircuitry by using neurostimulation or direct drug delivery. And it is reversible and modulable therapy. Another therapy is neuroablation, which is the permanent destruction, permanent deactivation of the specific areas of the brain, spinal cord, or peripheral nerves using various techniques. And the third one is neurotransplantation. So these are the three main verticals of functional neurosurgery. So out of those, the first one is the neuromodulation, which involves various techniques, various implants, like deep brain stimulation, spinal cord stimulation, dorsal root ganglion stimulation, peripheral nerve stimulation, etc. And out of those, one of the most common technique, one of the most common surgery which is being done in movement disorders is deep brain stimulation surgery. And deep brain stimulation has been approved by US FDA for 3 movement disorders, which are essential tremors, Parkinson's disease, and dystonia. And these are the 3 commonest movement disorders which are prevalent all around the world. So I'll be covering mainly these 3 movement disorders. As far as neuroablation or lesioning is concerned, there are various neuroablation techniques using radiofrequency, gamma knife, stereotactic radiosurgery, laser, cryo, all these techniques. And recently we have been hearing about focused ultrasound as well. So all these techniques are meant for making brain lesions or spinal cord lesions. And by that, we are alleviating many of the symptoms of the neurological disorders. So as we have already talked about the deep brain stimulation, which is being used, one of the commonest indications, one of the commonest therapy being used in movement disorders. Neuroablation, although it is quite commonly used all around the world, but unfortunately, there are no specific guidelines or clear-cut recommendations for using that technique. And especially because of the advent of functional neurosurgery, within the functional neurosurgery, the focused ultrasound, which we are hearing quite a lot nowadays. Because of focused ultrasound, the interest in neuroablation has again resurged. So for tremors and focal and segmental dystonia, this neuroablative techniques have been used. As I already mentioned, no clear-cut guidelines, but I will summarize in a way to understand where exactly this neuroablative techniques should be used. So especially whenever a disease process, whether it is dystonia, tremors, whether it is focal or at max segmental, which has failed the treatment of Botox with frequent Botox, and those kind of situations, neuroablation and neuroablative procedures have to be used. The disease process has to be unilateral. It can be either primary or secondary. And in general, primary pathologies, primary problems have got better results when they are treated with these techniques. And the secondary, due to any secondary reason, whenever there are these movement disorders, they are relatively difficult to treat and the results are not as good. And when we are talking about the primary disease process, even though in initial stages it might seem like it is a focal disease, for example, focal dystonia or writer's cramp, over the period of time, it quite frequently seen that it progresses and involves the various parts of the body. It becomes segmental, it becomes generalized. Like for Parkinson's also, initially it may present with tremors, but over the period of time it progresses. So it is very important to consider the progressive nature of the disease whenever we are deciding for this neuroablative techniques, because this is non-modifiable, non-modulable, it is irreversible. And whenever there is a presence of symptoms on both the sides of the body, whenever it is bilateral, then it is frequently been emphasized that unilateral abrasion is still it gives good results, but whenever it is done bilaterally, the side effects are very significant. So that part has to be considered, and primary goal is to improve the dominant side of the patient whenever we are using these neuroablative techniques. As I already mentioned, it is irreversible, risk of recurrence is there, and it might require redo procedure. It is non-modifiable. All these things have to be communicated with the patients and patients' relatives. And whether there is a financial constraint or patient comes from remote areas, especially if you consider the ecology of India, many of the patients, they travel quite a long distances to get these treatments done. And if you ask them to come for frequent follow-ups, it might not be always possible. So in this type of scenario, neuroablative techniques might be considered. But as it is to emphasize, there are no clear-cut evidence, no RCTs, no long-term data available for neuroablative techniques particularly, including focused ultrasound as well. So that is what is the main difference between deep brain stimulation and other neuromodulation techniques versus ablative techniques. It is irreversible, while neuromodulation and deep brain stimulation and other neuromodulation techniques are modifiable and modulable. and they are reversible. That is what is the most important difference. So now coming to the main part of the talk, my main part of the talk, that is management of movement disorders, and I'll be talking on Parkinson's, tremors, and dystonia. To start with Parkinson's disease, the deep brain stimulation is the gold standard treatment option when the pharmacotherapy has got limitations. And this usually happens after the period of 4 or 5 years when patients start requiring higher doses of levodopa. They get wearing offs, dyskinesias, fluctuations. And at that point of time, the deep brain stimulation is the ideal and only level 1 evidence treatment option which is available. As far as the tremors are concerned in Parkinson's disease, the tremors usually they respond well to levodopa, but not always. So it might happen that in many of the patients with Parkinson's disease who have tremors, they might not respond very well to levodopa. Despite that, this tremors can be very much well controlled with deep brain stimulation. So the rule of thumb in Parkinson's disease that DBS improve the symptoms which are improved by giving levodopa. The only exception is the tremor. So tremors can be very well controlled with deep brain stimulation surgery, especially even when they are not getting controlled with levodopa. So what does the DBS do in Parkinson's disease when it is done? So it increases the on time by 4 to 6 hours per day. It reduces the severity and duration of the off time. It reduces the bradykinesia, rigidity, fluctuations, as well as tremors, as I already mentioned. And because of this, there is also a possibility of reducing the dosage of levodopa, which in turn gives improvement in dyskinesia as well. So there is significant reduction of dyskinesia after the levodopa dose is reduced. So this is how it can be a life-changing procedure for patients with Parkinson's disease. So in the interest of time, I'll not be going into the details of all the major studies, but in crux, if we talk about the evidence about deep brain stimulation surgery, there is a lot of data, multiple RCTs, meta-analysis, which is available, including very long-term data of 15 and 20 years. And it has been shown that DBS has got sustained motor improvement in Parkinson's disease. And many of the studies have even shown that it has got some amount of a neuroprotective effect. It slows down the progression of Parkinson's as well. So on a long term, if you talk about the cost effectiveness, it is significantly cost effective as compared to other treatment options as well as the pharmacotherapy. So that is why it has got the level of an evidence in Parkinson's disease. And I'm just showing the representative video of one of the patients we operated. You can see the tremors in left lower limb and right upper limb. You can see the bradykinesia, which has got significant improvement after deep brain stimulation surgery. And if we see about the gait of the patient, there is slow gait, as well as there is significant amount of freezing while turning that has significantly improved, and patient has become almost normal after deep brain stimulation surgery. Similarly, you can see the medication off phase with or without DBS. You can see the difficulty in walking in off phase when medications are not given, but only DBS is working, medications are off, still patient is able to walk quite significantly well. Similarly, medication on phase, you can see the dyskinesias, and with deep brain stimulation on, with reduced medications, there are no dyskinesia which are seen in this patient. So most of the motor symptoms improve after Parkinson's disease after DBS surgery. So these are the tremor patients of Parkinson's, and you can see the system was off. Now we are turning the stimulation on after DBS surgery. So you can see instantaneous improvement and tremors on table after turning on the system. So this is how all the motor symptoms of Parkinson's disease improve after deep brain stimulation surgery. So if you talk about the recommendations as well as the evidence about rest of the other procedures, especially the ablative procedures in Parkinson's disease, nowadays because of the advent of focused ultrasound, the tremor predominant Parkinson's have been being treated quite frequently with focused ultrasound. But the thing is, on a short term, all these ablative procedures have got significant amount of benefit. There's no doubt about that, but we still have to be cautious by evaluating this immediate results. We have to still wait for the long-term results, because some of the radiofrequency studies which have shown this over the period of time, because of the shrinkage of the lesion size, there have been recurrence of the tremors over the period of time, but we still need to wait for the long-term result of focused ultrasound as well. So this is one of the patients we operated who had unilateral tremors. Intraoperatively, we had macrostimulation by using the ablation electrode itself, and we had got on-table improvement in tremors. And that was a lesion in ventro-intermediate nucleus of the thalamus on right side. So this was all about all the motor symptoms of Parkinson's disease, which improve after deep brain stimulation, as well as tremors, if we talk about, as well as for this ablative procedures. But there are certain issues related to Parkinson's disease, which are specifically, if you talk about gait disorders. So whenever gait disorders, or whether it is related to Parkinson's or it might be primary gait disorder, all these gait disorders, whenever, especially in Parkinson's disease, if it is responsive to levodopa, it definitely improves with the deep brain stimulation, as we have seen in the earlier video. But when they are not responding to levodopa in Parkinson's disease, as well as atypical Parkinson's, this type of patients, currently we don't have any US FDA approved and scientifically proven treatment available as of now. But there have been quite a few case studies, case report, and case series which are available, which have shown significant amount of benefit after spinal cord stimulation, whether it is high cervical spinal cord stimulation or mid-thoracic spinal cord stimulation. They have shown some promise in improvement of these gait disorders, but still we have to wait for RCTs and long-term results. So to conclude, for Parkinson's particularly, if the cases that of idiopathic Parkinson's with fluctuations, dyskinesia, and non-responsive tremors, deep brain stimulation is the only gold standard class 1 evidence treatment which is available. And if we talk about tremor predominant Parkinson's, which overall the proportion of the patients with tremor predominant Parkinson's is not that big, but still, if you find a patient with tremor predominant Parkinson's, still deep brain stimulation has to be considered as the first line treatment. But if there is some contraindication or patient is not willing to undergo deep brain stimulation, then RF ablation of the dominant side can be done by using ventro-intermediate nucleus of the thalamus to improve the tremors on the dominant hand. But we have to explain the patients about long-term outcome, the progression of the disease, and overall quality of life, because the opposite side is not going to be treated soon. And as far as the focused ultrasound is concerned, currently the cost of treatment with focused ultrasound is also very high. So I'm not very sure whether, as compared to deep brain stimulation, whether focused ultrasound is still justifiable or not. So that is still a question. So that was all about Parkinson's disease. Now we'll move towards tremors. So grossly speaking, I will not go into the details of types of tremors, but grossly speaking, there are mainly two types of tremors. It can be solely tremors predominant symptoms, no other symptoms, or there might be associated with tremor, there might be some associated dystonia, or it might be dystonia predominant and tremors are not that dominant, which are dystonic tremors and dystonic tremor syndromes. So in both the cases, whenever there is presence of dystonia along with tremors, we have to target ventrooralis nucleus, or there are other targets as well. While for only classical tremors without involvement of the dystonia, we have a couple of targets, so like ventro-intermediate nucleus or DRT, or in case of Parkinson's, there is subthalamic nucleus as well. So these are the main two types of tremors which have to be kept in mind while we are examining the patients with tremors and treating the patients with tremors. There was a seminal paper in 2018, which was a literature systematic review by Lausanne and group. So they have compared various treatment options for essential tremors. And as we all know, DBS being adjustable, reversible, and bilateral treatment possible at the same time, which is not true for focused ultrasound, gamma knife, and radiofrequency. And especially gamma knife radiosurgery and stereotactic radiosurgery has got delayed effect on tremors, unlike other therapies where we get instantaneous benefit in tremors. So they compared all these modalities, and what they found is quality of life was significantly better with deep brain stimulation because it was done bilaterally and there was bilateral improvement. But there was no significant difference in terms of side effects, if we talk about especially the ataxia, paresthesia, hemiparesis, and dysphagia, dysarthria, all these side effects, if we talk about, there was no significant difference. The only difference was that with deep brain stimulation being a modifiable and changeable treatment, reversible treatment, all these side effects would have been mitigated over the period of time with various change in programming parameters and side effects which were there, which they were not permanent as compared to other lesioning procedures. So this is what I have already told about. Various papers have shown various RF thelmotomies, focused ultrasound, and gamma knife thelmotomies. The only thing of concern in all these therapies in terms of tremor treatment is the side effect. That is the reason it is bilateral treatment is usually not recommended, because it will cause irreversible and significant side effects which will not recover. And it has been found that almost 30 to 40% of the patients will have permanent side effects after all these treatment options. So that is why whenever we think about treating these patients, we have to think about all the options very carefully, and we have to consider all the options. So as far as RF thelmotomy is concerned, still Movement Disorder Society Task Force had termed it as likely efficacious and possibly useful, as I already mentioned earlier, especially when it is done unilaterally. It has got good symptom relief, at least in short term. We have to still wait for long-term beneficial effects, and we have to wait for the results. The same thing is applicable to focus ultrasound, and focus ultrasound has also got the similar type of and similar incidence of side effects as RF thelmotomies. So apart from essential tremors, there are various other types of tremors which I already mentioned: Parkinsonian tremors, dystonic tremors, tremors related to multiple sclerosis, secondary tremors related to various strokes, especially the thalamic stroke syndromes, the Holmes tremors. All these tremors are secondary tremors and complicated tremors, and there is no specific recommendation to treat these tremors. But there have been variable results, and various options are still there to consider for each and every patient. So the treatment has to be tailored for each and every patient. This is one of the patients we operated, which was the post-stroke Holmes tremor. And you can see there was no complete reduction in tremor, but it almost around 80%, 70 to 80% improvement in tremors were found after the procedure. And we did the WIM plus VO thelmotomy in these patients. So this is what, as compared to essential tremors and Parkinsonian tremors, where we get significant amount, all more than 90% benefit in the tremor reduction, that might not be possible in secondary tremor syndromes. So the ultimate guidelines, which were given by this paper by Lozano and group in 2018, they have recommended the use of deep brain stimulation, whether it can be unilateral or bilateral, for all the essential tremor patients. And in the scenario of whether there are significant comorbidities or patient is not willing for undergoing deep brain stimulation surgery, in those patients, we have to consider focused ultrasound, RF ablation, or gamma knife thelmotomy in such situation. So this was all about the tremor. Now the last movement disorder, which is dystonia. And the treatment of dystonia overall, if you see, it is quite straightforward, because the dystonia basically largely we can divide into two parts in terms of treatment. If we talk about, it can be generalized dystonia or it can be non-generalized dystonia, which can be either focal, segmental dystonia. So if we talk about primary generalized dystonia, then there are very limited options available, and whatever medications, whatever pharmacological treatment is available, it is not that effective. And the role of genetics is very important in dystonia, and the same thing is coming up very robustly with Parkinson's disease as well. But if you talk about generalized dystonia, the genetic variants of DYT1, DYT6 dystonia, apart from that, the patients with cervical dystonia, Tourette syndrome, all these patients usually get benefited very well with deep brain stimulation surgery. And frankly speaking, there are no other options available for these patients for the treatment. And it is basically a life-changing procedure for the patients. So if you summarize the generalized dystonia, it is the deep brain stimulation, which is the first and only treatment of choice, which comes ahead of pharmacotherapy, except for the levodopa. We should always try levodopa in patients with dystonia, because there are variants of dystonia which are very much amenable for the treatment by using levodopa. But if that dystonia is levodopa non-responsive, it is generalized, or the generalized axial or segmental dystonia, and the genetic variants are favorable, then definitely the first treatment of choice would be DBS. The earlier done, the better the results of DBS are there. And we can have a significant amount of improvement, and the improvement continues over the period of time, and the benefit continues for years together. This is one of the patients we operated for generalized dystonia. This was DYT type 1. It started as focal dystonia involving right upper limb and gradually progressed to involve the bilateral upper limbs, neck and trunk. And he was not able to clothe himself. He was not able to drink water by himself. He stopped writing for last 14 years. And after this procedure, there was significant improvement. He started to live normal life. He started his own business and he's completely living normal life. He is doing all the activities by himself. So this is how the life changing procedure it can be. This is one of the dystonia which we find in patients with Parkinson's disease. It is a truncal dystonia, what we call at 𝒂𝒂𝒂𝒈, and you can see the significant improvement after the procedure, after the deep brain stimulation surgery. So this was all about generalized or segmental dystonia. So what about focal dystonia? So mainly the focal dystonias can be task-specific or non-task-specific dystonias. And always the initial choice of option is Botox in this type of patients, but over the period of time, the efficacy of Botox reduces. Then we have to think about the other surgical options. And there are various treatment options which are available for focal dystonia, like deep brain stimulation, RF ablation, peripheral neurectomies, dorsal rhizotomy for cervical dystonia, if we talk about. But as I already mentioned, like in tremor and other ablative procedures, there is no clear-cut evidence or no adequate data to floor out recommendations. But whatever data we have available right now, based on that, what we can conclude about dystonia is whenever there is a primary generalized dystonia, levodopa are non-responsive and appropriate genetic variant, then there is without any doubt that patient should be offered the treatment option of deep brain stimulation surgery. In cases of axial or segmental dystonia, still because this type of dystonia, they have higher possibility of progression, higher possibility of progression to generalized dystonia, we should offer deep brain stimulation surgery because it is not possible to inject so many muscles by Botox, and the ablative procedures might not have that much extensive effects in this type of dystonia. As far as focal dystonia and hemidystonia is concerned, definitely we should consider, if not deep brain stimulation surgery, we should definitely consider lesioning procedures like ventrolaris thelatomy, pallidotomy, or as I already mentioned, unilateral deep brain stimulation is always an option. And secondary dystonia, as in case with secondary tremors, the secondary dystonia also we should be very cautious whenever we are suggesting a surgical treatment option because the results are not that good. But still, if the secondary dystonias are focal and hemidystonia is there, pallidotomy is definitely one of the good options, and deep brain stimulation should be considered with explained risks of inadequate benefit in cases of axial, segmental, and generalized secondary dystonias. So this is what is all about all the treatment options. So the take-home message would be that movement disorders are complex and dynamic. That has to be considered whenever we are deciding for a specific treatment option at a given point of time. And diagnosis and decision-making is very important for the successful procedure. And for that, the multidisciplinary team approach is the must-have option to give the best results to the patients. Whenever we are deciding for an intervention, we should be answering 3 questions: why we are doing the procedure, which procedure has to be done, and when it has to be done, and what we are going to get out of this procedure. And whenever we are deciding for a particular intervention, because we have got lot many treatment options in functional neurosurgery, the patient should be in focus. The patient's problem should be in focus, not the therapy. So that is why the center, the surgeons, the physicians, all those who are involved in the treatment, they should have that holistic approach whenever we are designing for a treatment option for the patient. And we should consider drugs, injections, deep brain stimulation, lesioning procedures, as well as various peripheral procedures for treatment options. So in short, whenever we are deciding for a particular treatment option, we should not be a Maslow's hammer, we should not be knowing only one treatment option whenever we are deciding. So the team should be very much capable of, very much experienced about all the treatment options very clearly. They should be able to explain the pros and cons of all the treatment options whenever we are deciding for the surgery for the patient. So we have been the first such kind of team and first such kind of program in western part of India, and we have got the first Lexel Vantage and NeuroSmart Alpha Omega microdrive system in Western India. which is one of the best currently in the world. And I'm always indebted to all my gurus from whom I have learned the art and craft of functional neuromodular surgery, from the team of NIMHANS, from the team of Oxford, UK, my mentor, Professor R.G. Verma from Astro Bengaluru, Dr. Professor Cheng Mu from Philadelphia, US. So all those gurus I have learned, and I am always indebted to them for all the treatment options, all the this knowledge about all in this field, which I have imbibed from all these gurus. So this is my team, and from my team, I thank you very much, ACNS, for giving this opportunity to present. Thank you very much.
Thank you, dear Dr. Chirag. It was a wonderful lecture. So now the house is open for the discussion, and I would like to invite Dr. Tushit, my dear friend, to give some comments. Unmute yourself, Tushit.
First of all, thank you very much, Dr. Chirag, for a wonderful presentation on this topic. You have given almost a panoramic view for the functional neurosurgery to us. I would like to ask you one of the two questions that how does this DBS or functional neurosurgery help in atypical Parkinson's cases?
Yeah, that is a very important question, because whatever we have discussed so far in our lecture, all these treatment options are basically meant for typical Parkinson's patients. So deep brain stimulation surgery is also basically US FDA approved for typical Parkinson's only. It is not approved for atypical Parkinson's. And atypical Parkinson patients usually have these atypical features of predominant gait-related symptoms, lower cranial related, brainstem related symptoms. So for these patients, so far we don't have a specific treatment option available, although there have been a few studies which have shown some amount of benefit in gait, as I mentioned in my lecture also, by deep brain stimulation surgery of pontine pyramidal nucleus, as well as spinal cord stimulation. It has got some amount of promise for this type of atypical Parkinson's or Parkinson plus patients. But so far, we need to have more data to give them better option and better evidence that any such therapy is significantly effective in this type of patients.
Okay. Another one is that for the pediatric patient with the spasticity in cerebral palsy, does it help anyway?
Yeah, so that is a good question, because cerebral palsy, as we all know, that it is not as simple as we might think. It is a complex disorder, and it usually involves, apart from spasticity, there is some amount of dystonia. So that is why we call it dystonic CP. So there is quite a significant amount of overlap of spasticity as well as dystonia. So these patients have to be evaluated very much in clinical detail to know whether the dystonia is predominant, whether the spasticity is predominant. So if there is predominant spasticity which is there, which is causing significant issues with, I mean, for the caretakers of this CP child, or any other patients with any brain or spinal cord pathology with significant amount of spasticity which is there, which is not getting controlled with oral medications, this type of patient definitely benefits significantly with baclofen pump or intrathecal drug delivery, which we tell, which is a type of neuromodulation technique. So they benefit significantly well, and they do quite well with this technique. And whenever there is significant amount of dystonia, which is there as compared to spasticity in patients with cerebral palsy, then these patients can be given the option of GPI, deep brain stimulation, and that can help. Although the results, as I told earlier also, that basically cerebral palsy is the secondary type of dystonia. The results might not be as great as primary dystonia patients. But still, I mean, there have been quite a lot of evidence which is available to show that this type of children with significant amount of dystonia after deep brain stimulation surgery do quite well after surgery.
Thank you very much. Any new questions, Dr. Ishu?
Yeah, Dr. Sup. Please. Go. Ask.
Hi, Dr.
Hi.
Chirag. Excellent
Hi.
presentation. I
Thank
remember
you.
I connected with you around 2-3 years ago on this topic.
Yes. Yeah.
So my question is very basic and from a very larger perspective. For all those aspiring neurosurgeons who are watching the program and who will be watching us on YouTube, what is your what is your opinion on the fact that what are the kind of cases you have seen at the international level, at the national level in big centers, and now that you're working in a different state, what are the majority of cases that come? Because we just know of
So
places like epilepsy center and this is a DBS center. So those places have made a name. But what about the general population? What are the most cases that you generally see?
yeah. So that answer can be generalized. I think there might not be significant difference between the centers out of India, global centers versus Indian centers. So majority of the centers, functional neurosurgery centers all around the world, the major chunk of functional neurosurgery is basically Parkinson's disease. So I would say around 80% of the patients, 75 to 80% of the caseload would be that of Parkinson's disease, and rest of the patients might constitute that of other movement disorders, spasticity, gait disturbances, and all those things. So that is how it is worldwide.
Yeah, Alberto.
Yes, thank you. Thank you very much for the very nice presentation. I have a question about the new technologies like high ultrasound, focused high ultrasound techniques.
Yes.
So I would like to know your opinion because it looks like in the last years, this new methodology is taking over at least in a number of cases, also of Parkinson's disease. Of course, the main indication is essential tremor, but also for Parkinson's disease, many people are claiming this should be the first line therapy and not DBS anymore. So I would like to know your opinion about this trend which is emerging and which is quite controversial. I'm talking as in a position of a person who is doing also DBS surgery. So I'm really interested in your opinion about that.
Yes, very true. So thank you very much for the question. And you already mentioned that this is a burning question and a matter of hot debate in all these functional neurosurgery conferences. So if you talk about, as I already mentioned in my talk as well, that Parkinson's disease, particularly if you talk about Parkinson's disease, is a complex disease, and it is still an ever-evolving, ever-changing disease. So, as a treatment, if you talk about the lesioning procedure, whether it is focused ultrasound, whether it is the RF, the thing is, we are getting settled with a permanent, fixed, non-modifiable treatment option for these patients. So, the type of disease the Parkinson's is, because it evolves over the period of time. I still believe and I still expect on the long term that it is going to be that deep brain stimulation is not going to go anywhere, especially if you talk about Parkinson's disease particularly. And because of the focused ultrasound being a non-invasive therapy, it has got a lot of attention of the caregivers as well as the patients and relatives all around the world. But still, for Parkinson's disease, it is still being done for tremor predominant Parkinson's, not particularly for the other motor symptoms of Parkinson's disease. Although there have been case reports and various case series which have been there. And when we talk about lesioning procedure, any lesioning procedure, as I showed in my talk as well, that the lesion which we have generated initially, because the initial effect of the lesioning involves the permanent lesioning as well as the edema around it. So over the period of time, the edema resolves. Over the period of time, there are gliatic changes in the region of lesioning, and it has been shown that over the period of time, the size of the lesion also shrinks. So, as I mentioned in my talk, all this treatment modalities, especially the focused ultrasound, we need to have long-term results. Then only we would be able to conclude. But I still feel that it might not at all replace deep brain stimulation as far as deep brain stimulation surgery is concerned, with in terms of treatment of Parkinson's disease particularly. Still, there have been good data regarding essential tremors and tremor-predominant Parkinson's. So I think this type of patients we can still consider lesioning therapies, including the focused ultrasound. But as I mentioned earlier also, and it has been found in various focused ultrasound studies as well, whenever it is done bilaterally, the permanent side effects are significantly more, especially the gait disturbances, dysphagia, dysarthria. It is quite common. Almost 1/3 of the patients get these side effects, and these are permanent side effects if you talk about. So all these things have to be considered when we talk about all these newer treatment modalities.
Thank you. Thank you very much. I really agree about that.
I would
Thank you.
just say, Dr. Chirag is a true surgeon. Whatever surgeon learns, he says that's the best. We'll wait for time.
Yeah, very true.
Thank you. And one comment, Dr. Chirag did surgery of my batchmate's father for Parkinson.
Yes.
He's doing wonderfully. They are very happy. So congratulations and thank you.
Thank you. Thank you very much. Thank you very much for this opportunity.
So are there any more comments and questions? So thank you, Dr. Chirag, for the wonderful lecture. And it was an excellent presentation. So I will now give the stage to Dr. Alberto. Please.
Thank you. Yes, thank you, Ishu. It was a great discussion also about this second talk. We have to thank both our speakers and also all the audience for the interactive discussion. Now we can move on to a third short lecture that will be delivered by Dr. 𝒓𝒒𝒂𝒈. I hope I pronounced the name correctly. She's a young doctor, a young neurosurgeon, but with a huge experience. She was telling me that she has been living in Japan for more than 2 years now, and we are all very interested in knowing about her experience, of course, in her country, her own country, but also in Japan. So please, Dr. 𝒓𝒒𝒂𝒈, you can share your screen and tell us about your experience. I think we cannot hear you because you have to unmute.
Can you see my screen?
Yes, we can.
Yes.
Perfect.
Yes. Thank you. Good evening, everybody. Today I'm presenting something about myself, and I'm very happy to be here, Fujita Health University Banta Hospital. Speak about the study at Hamamatsu University School of Medicine, sharing experiment and future plan. And my background, my name is 𝒓𝒒𝒂𝒈. Can you call me Hoài? And I'm the lecturer and neurosurgeon at FHU University of Medicine and Pharmacy. And I'm very interested in the volunteer and interpreter when I'm the medical student. And I study a researcher in Hamamatsu University School of Medicine with a spine and some publication for the neurosurgeon in Vietnam. And so I can speak a little bit Japanese language. And my full name 𝒓𝒒𝒂𝒈, and I'm very lucky because my professor support for me to study in Japan, and I had a short time in the Sakura Science Exchange Program in Tohoku University, and so I chose Japan for the next step to study PhDs. And in Hamamatsu University, I met an international student and study more, especially the culture, the history, and in Japan. And also, I'm very lucky because I met my supervisor, Machiyama, and he gave me for lots of chance to go to the conference and study more. And I'm very lucky because sharing experiment from the Professor Yamamoto in Hamamatsu University. And I had a basic research in the organ and tissue anatomy department with the Same Yamagishi sensei. And experiments, sharing experiment, I studied in Hamamatsu University with the two departments, orthopedic surgery and neurosurgeon with the Kurozumi sensei and Matsuyama sensei. In the department of orthopedic surgery, I studied spinal surgery, especially the deformity, spinal deformity, and OPOL and lumbar spinal stenosis and lumbar spondylosis. And in the neurosurgeon, I studied with Kurozumi sensei and Samesima sensei. With the Kurozumi sensei, I studied especially the pituitary tumor with the endoscope, and with Professor Samesima sensei, I studied about the brain tumor. And also, I go to the Hamamatsu city with a lot of beautiful landscape and Hamamatsu Castle and museum and Hamanoko Lake. And so beautiful place when the weekend I can go somewhere. And once again, very lucky because I met Dr. Huy from Vietnam, and I met with Professor Yoko Sensei in the conference, neurosurgeon conference, and I hope to study more with her and CSF, and now I'm staying here for the Fujita Banta Hospital. And once again, I'm very lucky because I had a presentation for younger neurosurgeon webinar, and once again, Kato Yoko Sensei can go to the Ho Chi Minh in Vietnam for the Vietnam Neurosurgeon Conference 2024. And before go to the Fujita Bantan Hospital, I had a short time go to the Kenya trip for the volunteer in the treatment for the children and adults in the Kenya. And very lucky because I met a lot of the doctor in Japan and a doctor in Kenya, and I study more and fill the blanks. 私の使命は民放人と年寄りと子供の病院で作る状態です。So now I want to focus, study step by step, and make to my dream. And this here for the some volunteer activity when I the medical student and resident doctor. And so I'm very lucky because I met a lot of people give for me some experiments, and I want to focus on my dream. And future plan, I want to come back in Vietnam, Da Nang city and Hue city, and show some beautiful play in Da Nang and Hue. This here the Ngũ Hành Sơn Mountain, Linh Ứng, Pagoda, Bana Hill, and Da Nang Beach, so beautiful play. And also the Hội An Tower, Han River, and Bana Hill. And also in Da Nang, so a lot of the fruits from new store of both rose rice sticker and chicken eggs, so delicious. 美味しいですね。And in the Hue, you can go to Nguyễn Dynasties, Thiên Mụ Pagoda, Hương River, or Nhã Nhạc Cung Đình Huế, or Đông Ba Markets. And also the very delicious, the food traditional cake and coconuts with the black bean for the sweet soup, and also the nem giá. And once again, I invite the younger doctor go to Vietnam Young Neurosurgeons Conference and Neurological Nursing Conference 2025 in Huế Central Hospital in the July this year. And my area of interest is about the endovascular diagnostics and treatment and cerebrovascular surgery, special endoscopic MVD. And so I want to stay in here and follow this Kato Sensei and Komachu Sensei to study more. Once again, thank you very much and welcome to Vietnam.
Thank you very much. You are having really an impressive experience abroad, and I hope you will get the most. Well, I'm sure that with Professor Kato, you will have a lot to bring back to your country. And I wish you all the best for your future career. I think you will be able to bring back to your country a lot of experience abroad. So congratulations.
Thank you so much.
Is there someone who wants to give some words of encouragement to Dr. Dinh? Dinh, right?
Can you call me Hoài?
Hoài, okay, Hoài.
Yes.
One comment. Best of luck, Dr. Hoài.
Thank you.
Okay, maybe Professor Kato wants to say a few words.
Thanks so much. So Dr. Hoy, she went to 𝒂𝒑, the neighbor, the prefecture yesterday, the whole day, the local conference, maybe till the midnight, I think, from the morning. So she learned the notes. Even the whole presentation is done by Japanese, but she can understand the Japanese a little bit. So I think she had a great time with the Japanese local neurosurgeons. And also, she's very, very serious. So every day that she's taking a note, maybe the few pages. Congratulations. So we do the best for you, I think. Thank you very much. And also, already 𝒂𝒂 has left. Maybe we can have another 2-3 hours, another lecture from him in the future, I think. And also, Dr. Solanki, I think that I have the Parkinson, the patient. The effectiveness of the surgery is any stage of the Parkinson disease. Is it the same or earlier is the best?
Yes. So as per the recommendation, the earliest we can do the surgery in Parkinson's disease is at least the time duration of 4 years has to be there. The reason behind that is many of the patients, it might be difficult to diagnose whether that patient is having Parkinson's disease or atypical Parkinson's. It is very difficult to differentiate between the two in initial years. So the minimum duration required is 4 years to do early deep brain stimulation surgery. And whenever a patient is having the complications related to pharmacological therapy, that is the best time to go ahead and give the patient that option of deep brain stimulation surgery. The reason being that the earlier the surgery is done, the better the benefit lasts, because it has been shown that deep brain stimulation also modifies the disease progression by its effect of some amount of effect as neuroplasticity, as well as neuroprotective mechanism, which has been proposed in various papers. So the earlier the surgery, the better the longer effectiveness which will be there. Because over the period of time, if the deep brain stimulation surgery is delayed due to some reason, then what happens is there are many secondary issues, especially related to psychological disturbances, various other complicated motor disturbances which start appearing. And at that given point of time, it might not be possible to get the same amount of benefit which we might get whenever the surgery is done relatively earlier. So that is what is my take on that.
Thank you so much. So looks out. So Albert, I think we had a great the three talks today. So maybe I think in the future maybe we can have a 1 point lesson, but maybe 3-4 minutes. How do you think, Albert?
Yeah, I think that would be useful to have deliver very specific, short but important messages. I think we can find a way to implement this kind of webinars. We are always striving to improve. We actually had a meeting, as you remember, in Japan, in Nagoya, 2 months ago, trying to improve the power of message delivery to young neurosurgeons. So I think this idea can be a very good one to make something better in an educational point of view.
Okay, thanks so much.
Thank you, Professor Kato. Thank you. I am wondering whether there are other new fellows connected who want to introduce themselves.
Good evening.
Yes, thank you, doctor. Please.
I am Dr. 𝒐𝒂𝒊 I am new fellow, now residing in 𝒂𝒂𝒂𝒈. I have come for 2 months, now almost 1 month has gone. I am working as an assistant professor in Department of Neurosurgery in 𝒑𝒓𝒂𝒂𝒂 Medical College, which is situated in Dhaka, capital city of Bangladesh. Bangladesh, you know, it is situated in Southeast Asia and surrounded by India, Bhutan, Myanmar, and Bay of Bengal. We are a very much populous country, but very few neurosurgeons, about 180 million people and only 250 neurosurgeons in our country. So a very much loaded job for us. And in our department, we have only 5 neurosurgeons. It is relatively a new neurosurgery department, but we are trying to give as much service as possible. About 20 neurosurgeons, neurosurgery we do in a month, and about 250 neurosurgery cases in a year. And we do mostly neurosurgical practices in spine surgeries, skull-based tumor surgeries, and cerebrovascular surgeries. We don't still have any neuroemergency or endovascular services, but we hope in near future we can start this with the help of Bangladesh government. Here I have learned many things. Previously, many fellows came from Bangladesh for last about 3 years, and as following their pathway, I came here and I learned many things and still learning. Personally, I am very much interested in skull-based neurosurgery and endovascular neurosurgery. My first choice is skull-based endoscopic neurosurgery, and I have different paper presentations for last 3 years in different seminars and conferences, mostly upon the cerebellopontine angle tumors, pineal region tumors, cavernous sinus lesions, endoscopic pituitary and non-pituitary endonasal tumors, like that. And I have several journals published, mostly on glioma and endovascular and endoscopic endonasal procedures. Here I already have met Professor Ghotto in Osaka Metropolitan Hospital, and I have met Professor Watanabe in Aichi Medical University Hospital, and I saw their skull-based works, especially Ghotto Sensei showed us a cerebellopontine angle tumors, and Professor Watanabe Sensei showed us a endoscopic endonasal procedure and exoscopic cerebellopontine angle tumors. That was a very much new experience for me. Olympus exoscope, which is not available still in Bangladesh. So in near future, my plan is to do fellowship in 𝒂𝒂𝒂𝒂𝒂 neurosurgery, and I have a wish to start endovascular and emergency setup in our medical college hospital with the help of Bangladesh government. And lastly, I want to thank Professor Alberto for inviting me and giving me opportunity to introduce myself in this prestigious meeting. Thank you.
Thank you, Dr. Syed, for your introduction. I think there is another new fellow who needs to introduce himself.
That's all, I think.
Okay,
That's
okay.
all.
So, okay, great. So welcome to both of you to Fujita Bantane Hospital, and we all wish the best for your Japanese experience. So we have come to an end of this webinar. We have already heard the comments by our mentor, Professor Yoko Kato, and we want to thank her again for always supporting our activities. I'm sure that today young neurosurgeons learned a lot from our speakers, and we are very grateful to all three of them. So thank you all for your attendance, and I will see you in 1 month for the next Alumni Association webinar. Thanks to all of you, and also to our discussants and my co-moderator and the discussant 𝒂𝒂𝒂𝒂, our dear friend.
Okay, thanks so much.
Okay, thank you.
So,
Thank you.
So,
Bye bye.
okay. See you again. Sukit, thank you very much.
Okay,
Nice comment.
Right.
Bye.
Thank you.
Where's
Right.
Side?
Arigato.